We are live.
Good evening. Welcome to Retinoblastoma 2024. This is an international symposium. Obviously, this is the International Retinoblastoma Awareness Week that is coming up from May 12th to 18th. And this is in association with the International Retinoblastoma Awareness Week. It's an event in association with that. And this also includes a retinoblastoma quiz. And this particular symposium is organized by the All India Ophthalmological Society. Chairperson for the symposium is the president of ISO, International Society of Ocular Oncology, Dr. Dan Gombos, who's from MD Anderson Cancer Institute, Houston, Texas. And co-chairperson with him is Dr. Ashwin Reddy from the Moorfields Eye Hospital. We have moderators, Dr. Fairuz PM from Bangalore, India, and Ritika Sen from Chennai, India. We have the entire spectrum of elite faculty: Ashwin Malipatna, Swati Kaliki, Matt Wilson, Amita Mahajan, Carol Shields, Mahesh Shanmugam, Francis Munia, Bhavna Chawla, Jesse Berry, Rachna Meal, Ralph Eagle, Kaustubh Mule, Murli Chintagumpala, Helen Damaras, Usha Kim, Didi Fabian, Sima Das, and quiz will be conducted by Dr. Olika Bansal.
Thank you. And I'm going to move on to the next presenter now. It's my pleasure to invite Professor Aido Didi Fabian, who's the professor and director of Sheba Global Ophthalmology, Sheba Medical Center, Tel Aviv, Israel. And he'll be talking to us about retinoblastoma. How are we doing around the world in 2024? For the discussion, we have Dr. Seema Das, who's the head of ocular oncology at Shroff Charitable Eye Hospital, New Delhi.
Thank you for the introduction. I'll just share the screen. Can you see my screen?
Yes.
Okay. So thank you for the invitation. I was asked to answer the following question about RB around the world in 2024. And frankly, my immediate answer would be, I do not know. We are in the process of collecting the real world data. So please ask me again next year. But since I have nearly 8 minutes to speak, I'll try and do my best. So first, we need to know how many new cases of retinoblastoma are there in the world in a year. We know that the incidence of RB is constant across countries, and we know the birth rate in each country. So we can easily do the calculation, the result of which is about approximately 8,000 new cases every year. But how are they distributed globally? So most of what we know about RB comes from high-income countries, but in fact, these cases from North America, Europe, and Oceania represent about even less than 10% of global RB, whereas most cases occur in low and middle-income countries in Africa, Asia, and Latin America, over 80% of the cases. Now, in September 2018, the WHO, the World Health Organization, announced a new effort, the GICC, the Global Initiative on Childhood Cancer, with the aim of reaching at least 60% survival rate for children with cancer by 2030. These are the 6 index childhood cancers that were chosen. Retinoblastoma, one of them. Now, in order to reach the 60% goal, you need to know the baseline status. What is the status now? So in 2017, we founded the Global Retinoblastoma Study Group with an attempt to recruit all RB treatment centers across the world. All the panelists, or most of the panelists in this symposiums, are taking part, and many, many others. The idea was to have a very simple cross-sectional analysis of treatment-naive children that presented locally during that year, 2017. So basically, our goal was to report the very basic data on RB, but on a global scale for the first time. We managed to enroll more than half of the annual global incidence, more than 4,000 children from 153 countries, many, many collaborators. It's a lot. Is it enough? I'm not sure. This is the distribution, with dark red representing countries with more than 100 patients per year. So USA, Nigeria, Egypt, Pakistan, India, China, and Indonesia. Here are some of our key findings. So nearly 100% of children from high-income countries, this column, present with intraocular tumor, and their presentation age is less than 2 years of age. whereas half of children from low-income countries present like this with extraocular retinoblastoma and at a mean age of 3 years. What about the rate of familial retinoblastoma? So the answer is, it depends. It depends on where the child comes from. So in high-income countries, the rate was 8.3%, whereas in low-income countries, it was as low as 2.8%. And the reason, most probably, is because children from low-income countries that present exactly like I showed you in the previous slide do not make it to childbearing age. So the pool of familial cases in these countries remain low. We showed on another sub-analysis, this was done by Andrew Stacy, my colleague from Seattle. We showed for the first time that in Europe, the incidence of retinoblastoma is actually higher than we thought. 1 in 13,844 live births, compared to the historical figure, 1 in 15 to 18,000 live births. And on regression analysis, the only risk factor for higher incidence was positive family history. So in fact, the genetic pool of RB is on the rise in Europe. We then asked centers to continue monitoring those children that presented in 2017 for 3 years. So the latest outcome data we have on a global scale is from 2020. In high-income countries, nearly 100% of children survive after 3 years from presentation, whereas in low-income countries, just over 50%. But when you look at the capture rate by income level, so low, lower middle, upper middle, and high, in low-income countries, most of which are in Africa, we enrolled only 40%. That's in blue. We missed about 60%, so a lot, but not enough. We further looked into risk factors and found that if your risk factors for poor survival, and we found that if you're born in a low-income country, in Malawi, for example, or Uganda or others, and diagnosed with retinoblastoma, you have nearly 17 times increased risk to die as an independent factor than if you were born in a high-income country, in the UK or US or other high-income countries. Advanced tumors, CT4, so extraocular disease at presentation versus or compared to CT1, early intraocular disease, 9 times increased risk. And this is the respected Kaplan-Meier. So more than 90% survival after 3 years for intraocular disease, CT1, 2, and 3. But if you presented and diagnosed initially with extraocular disease, CT4, only about 30% survival after 3 years. 1 in about 30 children with retinoblastoma still loses both eyes, which is tragic, but saves lives. About the same time, we published the real-world data. Emily Wang and Jason Yum from Hong Kong, which are part of the global collaboration, published a 40-year systematic review and meta-analysis on global retinoblastoma. As expected, poor survival in low-income countries, mostly in Africa, looking at the details, while in middle and high-income countries, 1980s until 2020, survival rates improved since the beginning, since the 1980s. In low-income countries, this column, it remained about the same. And surprisingly or unsurprisingly, they calculated precisely the same 57% that we found in 2020. As mentioned, we are currently enrolling children for the 2024 presentation, 2027 outcome study, and we have a new video. So compared to the 278 centers we had in 2017 or 2017-2020, we now have over 430 centers on board. We mainly focus, at present, we focus to increase the capture rate in populated countries such as Nigeria and China and India and others. In addition to the presentation and follow-up data, we also asked for the available modalities in each center. So this is relevant to 2024. So it's presented here, analyzed at 3 levels: center, country, and in the next couple of slides, by economic group. We have data sent by now by 347 centers from 127 countries. So enucleation is a prerequisite to be defined as a retinoblastoma center, so 100% of the centers. Pathology available in 97% of the centers and in 98% of the countries, and systemic chemotherapy in 95% of the centers and 94% of the countries. If you look at these, this is the core team you need in order to save a child. Analysis by economic grouping, so pathology available in 92% of low-income countries and 100% of all the remaining countries, middle and high-income countries. And systemic chemotherapy available in 84% of low-income countries and over 93% of middle and high-income countries. There's more information on focal therapy, availability of genetic tests, etc. So Amita and then Manesh showed the increase in use of IAC in India. Here's the trend in Africa, 2024. So IAC and IVIC, so intravitreal. So in 2017, only IAC was available only in 2 countries. I think it was Egypt and South Africa, and currently it's available in 8 countries. Okay, intravitreal chemotherapy was available in 2017 in 7 countries, and now more than half of the African countries, 20 countries, use IVIC. We need to remember that these modalities are efficient for eye salvage when patients present early enough, and in too many countries, this is still a major problem. So thank you to all co-authors, about 700. I echo Dan Gamba's words. Collaboration is the way forward, especially in a rare disease like retinoblastoma. Thank you.
Thank you so much for the wonderful presentation. Dr. Seema,